Today, we are going to discuss cataract. The word cataract is derived from Latin word meaning waterfall. In cataract, there is all initially hazy vision as if we are looking through a layer of water. A normal human lens is transparent. It's a refractive medium which focuses light on the retina. Normal human lens, which is transparent, has no blood vessels. That is the speciality. Uh, Special arrangement of lens cells and fibers transmit the light. New lens cells are formed by anterior lens capsule. The lens capsule works as a semi-permeable membrane which separates the solid lens from the liquid aqueous humor. An active pump mechanism of the maintains the lens to remain relatively anhydrous, which keeps the lens transparent. If a uh, solid structure object is kept in liquid medium, it will absorb water and swell. But our lens, although surrounded by aqueous humor, will remain uh, anhydrous because of this active pump mechanism. Any break in the anterior lens capsule or reduction in its function to keep the lens relatively anhydrous leads to lens to become translucent and ultimately opaque. Thus, that is what is called cataract. Proteins of natural human lens are soluble proteins. Once the fluid enters the lens, it converts the soluble proteins into insoluble proteins, which are opaque. Thus, a lens becomes translucent or opaque. In sclerotic cases, there is pigment deposition in the lens, which affects the transparency and the lens becomes opaque. So, there are two mechanisms how the lens, a transparent lens, will become opaque. So, by definition, opacity on or within the lens due to loss of its transparency, uh, which may be because of hydration of lens fibers and denaturation of the lens proteins. As in this figure, you can see the lens is being suspended in the eye behind the iris by the zonular ligaments attached to the ciliary body. Behind is again vitreous, which is also having fluid. It's a jelly-like structure, but anterior chamber and the posterior chamber both are filled with aqueous, which is watery. Anatomically, this lens develops from surface ectoderm. It is a biconvex, avascular transparent structure suspended by zonules behind the iris. It has a central nucleus, cortex, anterior and posterior capsule. 65% of lens is composed of water, 35% protein, and traces of minerals. Thus, these proteins are albuminides and albumin and globulin, which are soluble. This is the central hard nucleus, which is surrounded by the, the cortex and epinucleus, and then anteriorly it is the anterior capsule, posteriorly it is the posterior capsule. It works as a refractory surface, and it also helps, the natural lens also helps in accommodation, meaning adjusting the light to be focused on the retina for distance as well as near. We can see the near object by changing the refractive power of the lens, and that is the function of the lens. So once the lens is removed, this function of accommodation will be lost. Now we can classify the cataract by various methods. One is the age-related cataract, which is the most common cause of cataract. That is the senile cataract. The second cause of cataract is traumatic. It can be a penetrating injury. As I told, if the lens capsule breaks, the aqueous will enter the lens structure and will dissolve will convert the proteins from soluble to insoluble proteins, and thereby very fast a cataract will be formed. Also in the blunt injuries, the lens membrane permeability is affected and it can cause cataract. Infrared radiation and ionizing radiation also can affect the permeability of the capsule, thereby causing the cataract. There are certain other causes like metabolic causes. In diabetes, in highly uncontrolled diabetes, galactosemia, hypocalcemia, Wilson's disease, galactokinase deficiency, all these can cause early cataract, whereas in the most common cause is the senile cataract, the age-related cataract. Even uh, high use of steroids, corticosteroids, chlorpromazine, long-term use of myotics as is being done, was usually done in the glaucoma treatment of glaucoma when no other drugs were available. This pilocarpine used to cause long-term use of pilocarpine used to cause complicated cataract. Anterior uveitis, whereas the permeability of the of the lens capsule affects because of the changes in the quality of aqueous. High myopia also can lead to early cataract, and chronic vitreoretinal disorders can affect the transparency of the lens, thereby causing cataract. The other way of classifying the cataract is congenital and developmental, that is hereditary. In maternal prenatal infection as rubella or toxoplasmosis, especially in first trimester of pregnancy, can lead to a child born with cataract. Maternal drug ingestion, then inborn errors of metabolism. They are the different causes of cataract. Sometimes a presenile cataract, early cataract may develop in dystrophia myotonica and atopic dermatitis also. Use of steroids in these conditions may also add to the early formation of cataract. Now the cataract as such, as per its maturity, is again can be classified into different stages. The immature cataract. The immature cataract is one where the whole lens is still not opaque, but part of it has become opaque. Initially, when the fluid enters in the lens, penetrating through its the anterior lens capsule, leads to hydration of the lens, and there are fluid vacuoles formed between the lens fibers. Ultimately, leads to swelling of the lens. That is called intumescent cataract, where the lens swells. When the lens swells, it bulges anteriorly and it presses on the iris to go closer to the cornea, especially in the periphery, and this may lead to phacomorphic glaucoma. In mature cataract, the whole lens becomes opaque, and which is very commonly seen when the patient do not turn early for the examination or treatment. But many times patients even do not come when they just have vision of hand movement. And there the mature cataract will turn into hypermature cataract. Sometimes it gets subluxated because of the degeneration of zonules, uh, and the lens may dislocate. The cortex may become liquefied and the nucleus uh, within the capsular bag sinks down within that liquid. That is called Morganian cataract. So a cataract from uh, uh, from a transparent lens gradually transforms into a mature, immature to mature, then hypermature, and maybe Morganian cataract. Now, these are some pictures of the nuclear cataract. Uh, they initially, when the central part of the cataract, the nucleus uh, becomes opaque, start getting opacity, then uh, uh, then myopia is being induced. This time, many patients who are hypermetropic will get better vision without glasses as they were using glasses, but now induction of myopia neutralizes their hypermetropia, and for some time they said they are able to see without glasses also, and they feel it as if they have got a second sight. But ultimately, this will go on and the myopia will increase, and again the patient's vision will go down. In the sclerotic cataract, there is a deposition of pigment in the nucleus, and it becomes from yellow and then ultimately brown or black. These are some pictures where there are few vacuoles formed in very initial phases, but this fluid in the or water which enters the lens, that converts the soluble proteins into insoluble proteins, and such cortical spokes are formed in the initial phases, but ultimately the whole lens is going to become opaque. So in immature cataract, some uh, some part of lens will become opaque. So when you put the light on the iris, there is a transparent area between the iris and this opaque lens, uh, the transparent part of lens, that will form an iris shadow, black shadow, and that indicates that lens has not become totally opaque. But ultimately, this lens will become mature, total opaque. Then in the hypermature cataract, sometimes this lens capsule can get calcified and may shrink also and will become very hard. So even when we go ahead with the surgical removal, the cutting of the anterior lens capsule becomes very tough in hypermature, certain hypermature cataracts. And when the cortex becomes liquefied, then the nucleus will sink down, and that is the Morganian cataract. There may be certain uh, in the early cataract, white punctate or snowflake posterior anterior opacities are formed, and uh, in the cortical and subcapsular opacities, they may progress to depending on the location, they will affect the vision. So if the opacities are in center, then the vision is affected even when the rest of the lens is transparent. When the pupil is small, this opacity will affect the uh, passage of light to enter the eye, and patient's vision will be decreased, especially in cases when the occupation of this type of this patient, if it is like driving, then any light coming from front, brighter light, will reduce the size, the pupil will constrict, and this opacity is going to obstruct the vision. And these patients, if they are drivers, they will find difficulty in the in the driving, especially in the night time or in very bright light. And this is risky for them and to their people to whom they are for whom they are driving. And therefore, the intervention might have to be done in such patients at their early stage. Now, what are the symptoms of cataract? There is a progressive decrease in the visual acuity, both for near and distance. There is a glare in the bright light, and in bright sunlight, if it is coming from front, especially, and also in the night time, when the patient is driving, when the lights coming from front, they will cause the they will lead to spreading of light, and the patient will find great difficulty in night driving. There can be a uniocular diplopia or polyopia, multiple images formed. They say some patients will complain that they are seeing multiple images of maybe moon or objects because of the light being passing through different partly opaque, partly clear media. There may be fixed dark spot in field of vision. That patient may complain, sir, I am not able to see clearly. There is a black spot in front of my eye. The nuclear sclerosis that making the patient short-sighted, good near vision, there is a myopic shift. So the patients mainly do not complain of any difficulty in vision, especially reading, because in uh, in their day-to-day life, if they were hypermetropic and now they are becoming myopic, they are able to see clear for the near, although their distance vision may be less. And but if it is within a small distance they are seeing, they may not really realize that they have a less vision. It is only when we will check them and show them on the chart, they are not able to see the lines on the chart, and thereby we tell them, now look, now you are not able to see clearly. So what are the signs of cataract? There is a reduction in the visual acuity, diminished red reflex on the ophthalmoscopy, opacity covering the pupillary area, and on slit lamp examination, we can identify the various details, finer details and location of cataract. If we examine a patient, even with the torchlight in mid illuminated room where the pupil should remain relatively dilated, you will be able to see a whitish reflex in the pupillary area, and that is very common sign of having cataract. Now, what is the treatment of cataract? Uh, can it be uh, can it be treated by some medicine? That is the most common question being asked by any patient when they come to know that they have cataract. They'll say, "Sir, I don't want." They've heard that a surgery has to be done, so they want to say that, "Sir, I don't want to get the surgery. So, what? How do you treat? How do you? What medicines will you prescribe me?" The uh, what are the indications of the treatment, surgical treatment? He said the only way of treatment is surgical. If the patient's vision is good to carry on his routine, we wait. Otherwise, the decreased visual acuity, which causes the disturbance in his daily work, like if a patient is not able to read comfortably, or is not able to drive comfortably, or is not able to cross the road comfortably, or he feels that he is not able to recognize any person coming in front of him, then that indicates now we should intervene and provide him with the treatment. Sometimes the lens will become glaucoma, will lead to the, the cataract will lead to what is called lens induced glaucoma. There are two mechanisms. Glaucoma is a disease where the intraocular pressure increases. That affects the optic nerve and reduces the vision permanently. Now, if already the patient has cataract, now if this cataract is swelling and that presses on the anterior part of it presses the iris anteriorly towards the angle of anterior chamber, then it occludes the angle of anterior chamber, thereby reducing the area from where the aqueous can be drained out of the eye, and that is called as achomorphic glaucoma. Sometimes the anterior lens capsule breaks, or it allows the proteins to leak out, and that increases the protein content of aqueous, and that is sometimes irritating to the interior part of the eye, and thereby it increases the and that high thick thick protein fibers, fibrils will occlude the passage of the aqueous, and thereby increasing the intraocular pressure. That is called phacolytic glaucoma. If the patient has to be treated from some retinal lesion, and there is a small cataract, but that obstructs the uh, examination and treatment of posterior segment lesion, we might have to advise for a cataract surgery. If the for cosmetic purpose, if the eye shows a white reflex which may not look cosmetically good, sometimes even a patient who has visual acuity nearly to hand movement or light perception, or even sometimes when the vision has gone to no PL. For cosmetic reasons, sometimes we have to remove this cataract. Patient does not like to have a white reflex in the pupillary area. When we have explained them that no, the vision will not improve even after surgery, still to avoid the problems of the hypermaturity of cataract leading to the glaucoma, and for cosmesis, we have to remove this cataract. When the cataract is in children, this poses a special problem, particularly if it is a unilateral cataract, because the patient's vision is within before in the early age. If the cataract is there just after birth or few years after birth, then the vision is affected, and if the retina is not stimulated with the good vision, then patient may develop what is called amblyopia, which means that condition where the patient's capacity of vision will go down, although the structurally the retina and things are normal. So to avoid this amblyopia, we have to give early treatment of cataract, especially in the unilateral pediatric cataracts. If there are bilateral dense cataract, then it must be operated as early as possible, even though it is done in some special centers where all the facilities to treat the small kids, and to give them anesthesia are also available, but it has to be treated. If there is a bilateral immature cataract, if the fundus details are seen, visible, operation can be postponed until the lens becomes more lens becomes more denser and the patient vision has gone down. Vision should be corrected with the contact lenses or intraocular lens in case of children. Sometimes pediatric patient, he may not be able to put the intraocular lens implant as the size of the eye is going to increase with the life, with the development. Whatever the power of lens we have put may not be correct to focus the light on the retina. So sometimes initially we do the surgery in two steps. We remove the cataract so that the visual stimulation starts developing, and the correction is made with the help of a contact lens. Or we have to explain to the parents that we might have to exchange the lens or put an additional lens inside, uh, which is also a way to treat the these type of cataracts. Uh, so basically, as I told you, there is no medical treatment. There are lots of advertisement and lots of publicity is being made. The cataract will be some drugs, miracle drugs will dissolve the cataract, but that is all false. There is no medicine which can turn the cataract, which has become opaque, into transparent lens again. No medicine. But if till the patient's vision can be made useful with refractive correction, keep on changing glasses every 5 6 months till his vision is being corrected for his need of vision, then we can wait for the surgical treatment. But if the vision of the patient with the best possible correction is not sufficient to complete the daily routine, surgery is the only option. So, and that is why the people they are afraid, they 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 do not want to get surgery, which is surgery is usually everybody is going to be is initially afraid because surgery, that's a word where the patients, a person gets frightened what is going to happen. But the cataract surgery is one such surgery which gives the best outcome. Of all the treatments, cataract surgery is termed as one of the surgeries which gives the best patient satisfaction. Now, history of surgical treatment of cataract. Cataract has been there since ages. You'll be happy to know it is mentioned in our Indian scriptures. Sushruta used to remove the cataract with a technique called known as couching. That time, the surgical treatment was not as advanced as what is today. They used to push this cataractous lens in the back into the vitreous cavity, and thereby the opaque media, the lens which are obstructing the visual axis, would be would fall down inside the vitreous cavity, and the patient vision would improve for some time. But that had lots of complications and problems, and therefore slowly new and newer, better and better techniques evolved, and uh, as I told you, the mature lens used to be pushed in the vitreous cavity, thereby improving vision. But then they started the old extracapsular cataract removal. Used to be done with a mature cataract only, with this incision. We entered the eye, removed part, opened the capsule, removed the nucleus, and then uh, the there was a in, the intraocular structures were washed with sterile solution, and the wound was closed without sutures. That too had certain problems. And then came the intracapsular cataract removal. The lens, the technique developed whereby we used to give a cut on the cornea at the limbus around 14 to 15 millimeters. The lens was being held with its capsule and was removed intact along with the uh, capsular bag, breaking the zonular ligaments. And then the sutures were applied, and then later on the cataract aphakic correction that led to what is called aphakia, no lens in the eye, and then the vision was rehabilitated with the help of a spectacle. Then uh, came the modern day extracapsular cataract removal with intraocular lens implantation. Now, this is the basic treatment now, that removal of the extracapsular cataract removal with intraocular lens implant. That is the now surgical treatment for cataract. Uh, Before surgery, before every surgery, we will be doing some investigation. So, basic examination, then we want to rule out the systemically if there is any medical problem, any history of hypertension, any history of any cardiac abnormality for which patient is taking any medicine, asthma or other respiratory problem, diabetes, any urinary problems, any drug allergies, any medication history, whatever treatment he is taken. All these are being uh, examined and history being taken for before the cataract surgery is being planned. Then the local examination. In local examination, condition of lids is being seen. If there is a infection in the lid, then a cataract surgery may lead to some problems, maybe infection, and therefore first treat the lid condition and then only operate the cataract. We see in the examination a pupillary reaction, brisk, good pupillary reaction, normal pupillary reaction is what is expected. Then any other local infection, any conjunctivitis or any other eye infection have to be ruled out. Then what are the local tests done before the local test before the surgery? So intraocular pressure. Intraocular pressure has to be measured. In, in older days, it used to be measured by shear tonometer, but now it is done by applanation tonometer, which is the gold standard, or even now non-contact tonometers are available, with which we measure the intraocular pressure before the surgery is being done. Then, very importantly, lacrimal passage patency. We do something called as Rupla's test or regurgitation test. We apply pressure on the junction of the uh, near the medial punctum, uh, medial canthus, and if there is a regurgitation of mucoid or mucopurulent fluid or watery fluid, then that indicates the patient has a coexisting chronic leukocystis. And if that at that stage, without bothering for the chronic diffuse cystitis, someone goes ahead with the cataract surgery, then it is sure that the patient will develop a severe uh, panophthalmitis or endophthalmitis because of infection entering inside the eye. So we test the patency of lacrimal passages by syringing. Syringing is a test where we'll anesthetize the congenital sac, we'll dilate the lacrimal punctum and pass a cannula filled with the normal saline in the direction of the canaliculus and push fluid. If the passage, lacrimal passage is open, the fluid will go inside the nose and patient will appreciate the fluid coming inside the eye. So there uh, we know that okay, the lacrimal passages are patent and we are free of attention that there may be some problem because of this. So intraocular pressure and lacrimal passage patency, these are two important local tests along with any to avoid, rule out any local infections. And systemic any infection. Uh, if there are uncontrolled diabetes, hypertension, any other condition, that has to be treated first, and then we go ahead for the surgery. Now, uh, these days, we replace the normal human lens, which has become a pet cataractus. We replace it with what is called an intraocular lens implantation. So that lens has to have its power, and that is measured by before the surgery. So that measurement of the lens power is being done by A-scan biometry. There are certain formulae which calculate the IOL power. So you have to fill in with the data of keratometry, the corneal curvature. The axial length is being measured by a biometer, by ultrasound method. So there are various types of techniques, various techniques, regular immersion biometer, contact biometer, and nowadays more advanced is a optical biometry, whereas with a non-touch technique, you can measure the axial length of the eye, measure the curvature of the cornea, the radius of curvature, and those data automatically are filled in the machine, which measures the possible and gives us a reading of what will be the type of lens or power of the lens which we are going to implant. If we implant a lens which has got a power higher than what is required, it will focus the light in front of retina. If it is very much converging, it will make post-operatively patient accepting a myopic correction. Whereas if the power of the lens which is used is less, it focuses the light behind the retina, then will the patient will need hypermetropic correction. Our target in the cataract surgery uh, is to provide the patient, if possible, with nearly zero power post-operatively, so that for distance he can see clearly. If the media are opaque, like cataract is mature, total mature cataract, you cannot see the inside of the eye. Now there may be associated, coexisting retinal detachment, and thereby when you operate, you will find that the patient vision does not improve because there is a coexisting retinal detachment. So to find out that, we have something called B scan, uh, whereas we can uh, measure, we can analyze the condition of the vitreous cavity before the cataract surgery, and thus assume if the retina is on, then uh, especially in the white cataracts or total black cataracts, it is always good to have a B scan done before the cataract surgery. So the question comes as when the surgery should be done. So cataract can be removed at any stage. Nowadays, the technology has improved so much, the results are so much predictable that you can remove even a normal lens, but it has to be done. Ideally, it should be operated when patient's daily routine or visual needs are compromised. I mean, if uh, I get a cataract and I still can have a good functional vision with glasses, by removing my cataract and putting intraocular lens and giving me again a good vision doesn't make any sense, because I can see without previous to the surgery also with glasses. So it is when the patient's vision does not improve with glasses, or is not sufficient for the vision is not sufficient with the available correction, his daily routine is being affected, then it should be operated. We need not to wait till the cataract to become total opaque. In the past, when the intracapsular cataract surgery was being practiced mainly, the patient was being told that, look, your cataract is not mature, and therefore you wait जब तक मोतियाबिंद पक नहीं जाएगा तब तक ऑपरेशन नहीं होगा. That was the version given to the patient because of the technique, that if the mature cataract was being operated, then there were larger chances of the if the some part it capsule breaks and some nuclear part of lens remains back in the eye, the vision may not develop properly. So therefore, that time, that technology, we used to say that patient should wait till the cataract becomes mature. But nowadays, we should be able to operate, and we do operate at the time when the patient's visual needs are being affected and cannot be corrected with the optical support. Then we should remove the cataract and replace it by an intraocular lens. So initially, what is the management of the cataract step by step? The initially, when till the vision can be corrected with the glasses and improving some light, then uh, the patient can carry on. But if the patient's vision does not improve with glasses and improving light, then we should the surgery is the only option. There are different techniques of cataract surgeries. Now, eco-emulsification is the most modern technique. Extracapsular cataract extraction is another technique. And intracapsular cataract extraction was the technique, but it is not performed as a routine now. Very rarely for dislocated lens, etc., we may use this technique, but otherwise we go ahead with the either phacoemulsification or a small incision cataract surgery, a manual SICs. Rarely, cataract should be removed even if it doesn't cause major problem with vision, if it is preventing the treatment of another eye problem, such as age-related macular degeneration, diabetic retinopathy, or a retinal detachment. The patient has a coexisting retinal problem as well as some cataract. For observation and treatment of the retinal problem, the cataract is creating an obstacle. Then Even if vision is not grossly reduced, still you have to operate. So these are the special indications. But otherwise, if the patient's vision is being affected, should be operated. What is being done in the cataract surgery? So the opaque or translucent lens is surgically removed and it is replaced by an artificial lens that is called IOL, intraocular lens implant, which works in place of natural lens and focuses the light on the retina. So after using IOL, need for thick aphakic spectacle is not needed. When in the era of intracapsular cataract extension, ICCE, we used to rehabilitate the patient by putting aphakic glasses plus 10 glasses. Uh, but now with intraocular lens, uh, which of which the power is being calculated by biometry, you can get a patient with the near zero, and therefore no glasses or a small number of glasses may be needed. Uh, Glasses of may be needed by of low power, and uh, it the vision is just very much similar to the normal lens. When the IOL was not used in past, in the older days when the IOL was not used, not invented even, we used to remove the opaque lens and refractive condition of eye then was called aphakia. Aphakia means absence of lens. In aphakia, the clear vision was obtained by prescribing thick plus aphakic glasses plus 10 diopter power, which was very thick and heavy. With aphakic glasses, although the visual acuity would increase and patient could see, but the size of image would be enlarged. So when the IL was not used, as I told you, the vision was being corrected with plus 10 thick phakic glasses, with which, although the vision was there, the size of image was used to be enlarged. That depth perception was altered, and the field of vision was restricted. This used to lead to a lot of uh, problems, although the vision was there. Uh, and if at that time, if the vision of the aphakia was only in one eye and the vision in the other eye was normal, then using plus 10 diopter lens in one eye and normal in the other eye, there used to be a binocular diplopia. So patient was not be able to use his aphakic vision, uh, though he could, because to avoid this diplopia. And therefore, now with the modern time, uh, this with putting IOL, this problem is overcome. These are the old time pictures where a plus 10 thick lens used to be given. The eye used to look enlarged, a very big size of eye, because seeing through a plus 10 lens, there would be enlargement of the size of image. So as if we see any person who is wearing plus 10 glasses, their eye looks to be large. Uh, it was awkward for patients, and especially in the movement on the street, the field of vision being affected, the uh, somebody coming from side and going ahead look like somebody jumping in front, because the field of vision used to be less or limited with the plus 10 glasses. Now, the difficulties of aphakic vision are not there with the pseudophakic vision. Pseudophakic means when the artificial lens is being put in the eye. So vision, that is vision with eye. But still some spectacle power would be needed, and near vision addition uh, has to be in glasses has to be used. So although we measure the intraocular power, the power of the intraocular lens before putting it, but there are certain factors which may affect and cause a little spectacle power even for the distance also. And for reading, as I told you, the natural lens has the capacity of accommodation, and an artificial lens cannot accommodate. Therefore, near addition has to be. Uh, if we use some special newer generation of IOL like trifocal IOL or multifocal IOL, then the dependency on the spectacle would be avoided. Now the technologies have improved. So a cataract is being operated with the intraocular lens implantation, and uh, a small refractive correction, whatever is needed, is being prescribed. Now, how do we go ahead with the cataract surgery? Any surgery for that matter will have it has to be done with what is called as anesthesia, so that patient does not feel any pain. In general, any pain, the patient will not be cooperative. And for eye surgery, the patient is specially apprehensive, and therefore it is a very delicate organ. So we have to provide anesthesia. Now, in general, abdominal surgeries, other surgeries, general anesthesia, but here general anesthesia uh, is used only in special cases. Normally, the cataract surgery is done under regional local block, facial and retrobulbar or peribulbar block. And nowadays, even we do without injection also, without giving any block. That is called topical anesthesia. We put the drops and topical, and some injection is being put in the anterior chamber, intracameral xylocaine, and thereby we can operate what is called as no injection anesthesia or topical anesthesia. Now, there are different types of cataract surgery, surgical options. Extracapsular cataract surgery is done by two basic methods. One is manual small incision cataract surgery. One is the traditional extracapsular cataract surgery. And third is called as phacoemulsification. And this is combined with insertion of an intraocular lens implant, IOL. Now, in cataract surgery, in the intracapsular surgery, we used to give a large cut from here to here, whereas in extracapsular surgery, we do a smaller cut And in phacosurgery, we use still finer or smaller cut. Uh, Depending on that size of cut, its effect on the corneal wound will lead to addition of some refractive error in the eye. Nowadays, cataract surgery is a microsurgery. We do operate under operating microscope. So, uh, when we this part of microscope is called ocular, and a bright light is being reflected on the eye, and a reflected back light is seen through these optics, and thereby we can see very fine, minute details of the eyeball, and we can operate very precisely. So we would talk of different types of cataract surgery. Extracapsular cataract extraction, ECCE. We'll give a limbal incision